everyone. Thank you so much for having me here. It's my honor to talk to you today about radiation options for kidney cancer. And as Dr. Singer said, radiation, 10, 15 years ago was completely unheard of when it comes to using it for management of renal cell carcinoma or kidney cancer. And so we'll talk about kind of some of the differences that we see in modern day. All right, so today I'll be kind of breaking down my talk in kind of three sections. First one is kind of to go over what is the radiotherapy option for kidney cancer, and specifically we're going to talk about a specific technique of radiation, which is stereotactic ablative radiotherapy, or short for SABR. And we're going to talk about how we're going to use SABR radiation for planning and delivery of radiation, and then to end the talk with a few different clinical scenarios and indications of where radiotherapy with SABR can potentially benefit patients with RCC. So as Dr. Singer just said, low dose radiation that we typically use, and that's the mainstay of radiation 15, 20 years ago, simply does not work for RCC. So it's not even something that we even consider. And now when we say low dose radiation, we call it conventional fractionation in the sense that we're delivering low doses, 1.8 to 2 gray per fraction over many weeks of radiation. And we still treat many cancers very effectively with these low dose, longer course radiation for many cancers, but we know that that simply does not work for RCC. But we know that high dose ablative radiation works very well, and that really comes with as technology improved, radiation delivery and imaging improved, that we're able to deliver very high doses of radiation over a short course of period of time in a safe and effective manner. And we're talking about in these scenarios are doses that are greater than 8 gray per fraction, so very large doses over a very short period of time. And we know over the past 10 years or so, both from the IROC consortium as well as the Australian group that ran the first prospective studies on using radiotherapy for kidney cancer, the Fast Track 1 and 2 studies, that we know the local control of using SABR radiation for treating the kidney lesion, the RCC lesion in the kidney, is very, very effective. And not only just the kidney lesion, but also metastatic lesions as well, as we'll talk about as well. So we're talking about control of 90-95% or higher in terms of disease control using radiation. And so how does it work? Stereotactic ablative radiotherapy, how it works is sort of in the name, in the sense that stereotactic means that this is a type of radiation treatment with greater precision and accuracy. Ablative, meaning that these are very high doses per treatment, not the low dose over a long period of time. But it is a specific form of external beam radiotherapy. And so how it works with the figure on the left, that's really showing kind of how the machine, what is the machinery within the external beam machine. We also call it the linear accelerator. So how it works is that there is a electron gun that accelerates the electron to a very high speed, and then it hits a heavy metal, tungsten, at the head of the machine. And as you can see with the radiation beam coming out, photon radiation beam coming out after the electron collides with the tungsten metal. And with the beam coming out, there is what we call jaws and collimators that you see on the right, where these are leaflets, or what we call multi-leaf collimators, that actually shape the radiation beam as it comes out. And with this type of modern technique, we're really able to shape the radiation beam so that we can minimize unnecessary radiation to the rest of the body that does not need radiation, and therefore minimize toxicity. Now, the radiation that comes out of the machine, these are what we call photon radiation. So they go through and through the body. So if it goes in from the front, it'll come out on the back end. And certainly you may ask, well, if the radiation goes through and through, how do we protect the body with this type of high doses of radiation? And so how we do it is with the modern delivery technique, which is what we call volumetric arc therapy. So it is a continuous arc that delivers radiation through multiple angles around the body. Sometimes it's all around, 360 degrees. In many cases for kidney, we're doing a partial arc, perhaps only 180 degree or 210 degree, where we're just focused on that side, of the body where the kidney lesion is located. And with this type of technique, we're delivering for any given angle as the arc goes around the body. At any given angle, only a very small amount of radiation is contributing to the total dose. And so meaning at any beam path, even though it goes through and through, the organs that comes in contact with the radiation only gets a really small amount, and all of the beam path intersect with the tumor target, which is the kidney lesion that we're seeing here, which is on the left side of this particular patient. And so the high doses get concentrated to the target, and the rest of the organs at risk gets a much lower dose. So for example, the skin is the first organ that comes in contact with the radiation beam. But because so little of the radiation is actually being exposed to any given part of the skin, for this type of treatment, we don't expect any skin reaction or sunburn, which is, in the past, most have heard that radiation can cause really bad, sunburn and skin reaction, which does not happen with modern day radiation. So we're going to talk a little bit about how radiation is planned, before we actually deliver. So it's a complex series of events that takes place, before radiation can be started. The very first step is, to be able to position the patient on the treatment table in a reproducible way for every single treatment. And so we use a specific immobilization device to help with that. And we call the type of immobilization we use, we call it the vac lock cushion or vac lock bag. Essentially, it's a bean bag-like material where if you lie on it, it conforms to the shape of your body, and we vacuum out the air, and it stays in that shape for that particular patient for their entire treatment course. And that way we can allow, not only comfort, but also reproducibility, of the treatment position every single day. And then the next step is do a quick CT scan with the patient on the CT scanner with the mold, underneath them. And with the images that we get, that's how we're going to design the radiation, before the patient gets their treatment. We're also going to be doing, tattooing and marking of the skin to also, as a redundancy, to help with aligning the patient as perfectly as we can underneath the radiation machine. As you can see in this picture, there are laser beams that come off of the side of the simulation room, as well as on the top, from the top. And that helps center the patient, on the machine when we're treating them, because these same laser beams are calibrated the same way in the actual treatment machine room as well. So how we design the radiation, how we set up the patient during simulation is exactly how we would set them up on the radiation machine for treatment. And as you can see here, this is the patient getting set up on the machine, and with the laser beams that come off of the wall to help position the patient. And this, this reproducibility, allows us to really have the accuracy and precision that we want for radiation treatment. And what you're seeing here is that the center of where we position the patient underneath the machine is what we call the iso center. And essentially, it's a reference point within the body, oftentimes on the tumor target itself, where all the beams converge as we're doing the arc treatment. And so having that kind of reference point when we're setting up the patient is really key to the precision and accuracy of the treatment. And so when we're doing radiation planning after the initial CT scan, we're going to design the radiation based off of the patient's anatomy from the scan. So not only are we oftentimes just using the CT scan, but we're using, in addition to that, the help with other diagnostic imaging such as PET scan or MRI to fuse it with the planning CT to allow, the most, tailored, planning of the radiation that we can. So what you're seeing here is kind of the step-by-step process of how we would design the radiation, starting off with the delineation of the target itself. And so the very first thing is to delineate where the gross tumor volume is, or where the disease lesion that we're wanting to treat. And so in the middle, you see that cartoon with kind of three circles and to kind of show the different volume of what we are delineating. And on the right-hand side, that's the actual patient in which we're planning the radiation for. So you can see that the gross tumor volume, in this case, on the right-hand side, that is the kidney lesion on the left side of the patient, and that's the target that we want to treat. But when we're treating the patient, more often than not, they are breathing freely on the machine. There's a different technique that we won't really go into detail, which is deep inspiration breath hold or expiration breath hold, where we have the patient hold their breath during treatment. So that's one way to do treatment as well. But more often, we allow the patient, for comfort reasons, to breathe normally, as they're getting the treatment for 2 to 3 minutes of time. And we know that as we breathe, our abdominal cavity, abdominal content, including the kidney lesion itself, will move up and down as we breathe, and sometimes even a little bit from side to side. And so we need to account for that when we're doing the radiation planning. And so that's where the internal target volume comes in. When we're doing the planning scan, we're not just doing a 3-dimensional scan, we're doing a 4-dimensional scan that takes into account of time. And so we basically make a video for each of the planning scans to be able to map out exactly where the internal organs as well as the tumor target will be at any given part of the respiratory cycle. And so we take that into account where we're designing the radiation field, and in this case, making the appropriate expansion from the gross tumor disease volume to make what we call the internal target volume. And that takes into account of respiratory motion and making sure that we're encompassing where all the tumor location can be during free breathing. And then finally, the last expansion from that volume is what we call the planning target volume, where we take into account the uncertainty of daily positioning. Of course, like we said, with the mold, with the marking on the body, with the laser beam, with the CT scan that we're doing before every single treatment, we can line up the patient, reproduce the position very well every single day, but there's can still be, a couple of millimeters of uncertainty from day to day, and that's where the planning target volume allows us to be even safer, with that uncertainty. And so this is just another image, showing kind of the same patient in terms of delineating kind of the gross disease, the larger, internal target volume and the planning target volume, but equally important to delineating the target is delineating the organs at risk nearby. Because not only do we want to make the treatment effective, but we also wanted to make it safe. And so we also design, contour out, the organs at risk to protect them during radiation planning. And so the very last step is a complex, set of algorithms that allow us to design the radiation. And so as you can see in this picture, because of the large bowel very close to the kidney, just on the side of the kidney, we're able to design a radiation so that the dose carve away from the large bowel and still able to deliver the dose that it needs, to the kidney target itself. Treatment delivery is only 3 to 5 treatments. These are very high doses, so very short course of treatment. During the radiation course, patients are in the department for about 30 minutes, about 15 minutes on the machine, and only about 2 to 3 minutes where we turn on the radiation beam. I apologize, I'm running a little bit out of time, so I'm going to be really quick for the last part. Side effects of radiation, there are local side effects, so it affects mostly irritation to the organs nearby, which are mostly bowel. And so nausea, diarrhea, loss of appetite, can be a potential acute side effect that usually goes away. Please go ahead. Yeah, good question. Yes, so meaning that if, let's say, a patient were to have, a metastasis to the liver, yes, the same type of SABR radiation can be designed to treat the liver lesion as well. Yeah. All All right, I know I'll just a couple more minutes, but I really want to end the talk with just a few kind of indications of how we use, SABR for radiation. We've already talked about kind of how we use it to treat primary disease. And as we said before, that the local control, not only treating the primary but also metastatic disease, we have a very good, usually greater than 90%, 95% of disease control. So we do use it as an alternative to what Dr. Dason and Dr. Wong mentioned in terms of surgical removal of RCC. We can use radiation as an alternative for patients who prefer a less invasive modality. And we can also use it to treat in a metastatic setting as well for cytoreduction. One thing I want to bring out is sort of how we evaluate response after radiation treatment. Unlike most cancer, where we expect that if the cancer lesion itself is appropriately treated, the lesion will disappear quickly and after treatment. That is true for most cancer, but not the case for kidney cancer. And this is a very important, for patients to understand as they go into the treatment with the expectation of what they should see on imaging. It can take months, years for the kidney lesion to respond to treatment, actually. But certainly that is not a sign of failure. That is just kind of what we expect for RCC. So just to kind of see here, this is an actual patient that I treated. This patient got treatment in November of 2022. And you can see on the top left, the September scan, that was before treatment. Then after treatment, a couple months after treatment, the tumor lesion looks about the same or even arguably a little larger. Same thing with the April scan on the left lower corner, where sometimes we see that with what we call pseudo-progression with likely inflammation that causes the kidney lesion to actually grow larger in size. But as you can see, in then October of 2023, then that's when the lesion started to really shrink dramatically compared to before. And so this is very commonplace when it comes to, following, the imaging, after treatment. A couple of other indications for renal cell carcinoma to use radiation: oligometastatic disease. When there is only limited metastatic disease burden, we can also use radiation to control all sites of disease if the disease itself is not yet very efficient in spreading. And so this is a patient of mine that only had disease in the lumbar spine and the kidney, and we treated both with radiation, and the patient has not needed to start any systemic therapy. In fact, there was a recent phase 2 study coming out of MD Anderson showing that in their protocol, some of the patients can with metastatic disease only get radiation treatment and able to delay the need for any systemic therapy for many, many years down the road. Another indication is to treat when the patient is doing well on their systemic therapy treatment, controlling 90-95% of their disease burden, but let's say there's only 1 or 2 lesions that are growing, then we can also use ablative radiation to target those progressive lesions so that the patient can remain on the systemic therapy they're on that is effective in controlling most disease. And this is a case that I recently treated for that very indication, where there's only 1 lesion that is growing, everything else is very well controlled. And then last but not least, palliation, where we can also use radiation to control symptoms as well as the tumor growth at that location as well. And this is a gentleman that came in with a lot of pain in the back, in the lower back, lower hip area from this invasive disease, and after treatment, shortly after, the pain has mostly resolved. So just to summarize, SABR radiation is an effective way of treating both primary and metastatic renal cell carcinoma, non-invasive, well-tolerated, and certainly it's an integral component of the multimodality approach to RCC management. Thank you, and I apologize for going a little bit over time.